We'll just go ahead and get started. My name is Olivia. I'm a fourth-year medical student at the University of Iowa Carver College of Medicine. I've been doing virtual rounds for like a year and a half now. So if you've been to some of these before, welcome back. And if you're new, it's great to have you. I think they're a lot of fun, and I hope that you guys are able to learn something today. We are doing a OBGYN topic. These are usually pretty highly requested. I get most of my topics based on your guys' suggestions in the feedback form. So if there's ever a topic that you're interested in, please feel free to drop a suggestion. And today's topic is going to be labor and delivery monitoring. So just kind of like a standard patient case of a normal labor and delivery course, and then some additional little lessons on fetal heart monitoring and things like that. So let me quick put the link for the SOAP note and quiz into the chat so that you guys can get that opened up. And I also have the Google Drive resource link with some common like acronyms and vitals and things like that in case you are interested in looking around for that. But without further ado, we'll just kind of get started. We'll start with our patient case and do our physical exam and have like a differential diagnosis. And then we'll work through the assessment and plan and then do a little lesson on pathology of disease. I wouldn't say that this is like a super pathology heavy. It's more just like general interpretation of like different fetal heart monitoring and stuff like that, but still good to know and very applicable for everybody's future career when you're going to do like OBGYN rotation or anything like that. So please make sure you have the SOAP note filled out or pulled up, and then we'll fill it out together during the presentation, and then the quiz will be at the end. And I like to make sure that everybody has a chance to go back to any slides that they might need to revisit to help with those questions. So if there's ever anything that you guys need to spend more time on, just let me know and we can always go back. So this is what the note looks like. Let me know if you have any troubles with the link. So we'll get going with our case now. Our patient is a 28-year-old G1 P0 at 40 weeks and 2 days gestation who comes into the labor and delivery triage unit with a suspected labor. So just a couple questions. First off, does anyone know what G1 P0 means? Like, why would we include that in front of the patient's history? And if not, then we're going to go through the answer here in a second. I just wanted to know. Adam totally got it right. Yes, it's her first pregnancy and she has no children. So that's what that G1 is, her number of pregnancies, and the P is her number of children. We'll go through that in a little bit more detail here in a second. And then what is the normal length of gestation? Like how long is a typical pregnancy? And you guys can either put in the chat or unmute, whatever you're comfortable with. Any guesses in weeks or months? 40 weeks. Perfect. Thank you so much. And then what would we like to ask her in taking our history, or what parts of the exam that we would want to do in order to either rule in or rule out that she's actually in labor? Any ideas? Yeah, if she's like having contractions regularly, that's like one of the biggest signs of going into labor, is starting to have regular increasing in intensity contractions. Maybe we'd want to ask her if she thinks that her water has broken yet. We might like to see if she has any like bleeding, or if she's still feeling good fetal movement. Let's see what else. Those are like the main things that come to mind for ruling in and ruling out labor. If she's having regular contractions, if she thinks that her water is broken, and then of course, like we'll want to make sure that she's still feeling baby move around and seem like normal behavior. That'll be reassuring to us as well. So as promised, going back to the G's and P's, our patient, like I said before, is a G1P0. So the first number that comes after the G stands for gravida, which is the number of pregnancies that a patient has. And then the P stands for para, which is the number of deliveries that the patient has had. So this is going to have one number after the G, and the P abbreviated would just have one number, and that's like the number of deliveries that they've had. But then you can further break it down into having 4 numbers, and it's going to go in this order. So the first number would be the number of full-term deliveries. So that's after 37 weeks of gestation. The number of preterm deliveries. So that's like any premature babies that are born before 37 weeks. And then third number is abortions, miscarriages, ectopic pregnancies, any pregnancy loss is going to be that third number. And then the last number is the total number of living children. So for example, if we had a patient that is a G3 P1011, and that would mean that they would have 3 total pregnancies, 1 live term birth, so born at term, 1 miscarriage, no preterm births, 1 miscarriage or ectopic or abortion, and then is also currently pregnant. So when you add up all these numbers together, you should get 3 in the front. And then a G2 P2002. So we just have these 2 term live births that are here again, like 2 living children, and they're not currently pregnant. And then a G4 P0131. That 4 is again their number of pregnancies. P0, so 0 term births, 1 preterm birth here, 3 miscarriages, and not currently pregnant. So if you put together those 3 miscarriages, 1 live preterm birth, that's 4 total pregnancies, G4. I know it's a little bit confusing, but if you just go in this order here, then you pick up on it pretty fast. And a lot of the times in clinical scenarios, they're just going to use the G1P0 or like a G3P3, and they're not going to break it down by the individual like term versus preterm, and just have it be shorter. All right, going back to our case now. So our patient started having contractions yesterday, and they've gotten closer together. They're now about 6 minutes apart, and they're also lasting longer. So they last for about 1 minute each. She does not believe that her water is broken yet, but she's asking for us to check anyways. And she still endorses that there's good fetal movement, so that's reassuring. She denies having any bleeding or any other systemic symptoms. And bleeding when you are about to go into labor can be normal. There's something called a bloody show, which is where like your cervical mucus plug can sometimes let a little bit of blood out with it. And that can be a normal sign of labor. But any like excessive, really bright red or like a large amount of bleeding would be more of concern. And then when taking the rest of our history, we find that her pregnancy has been completely uncomplicated, no pregnancy disorders, which means she's never had like gestational diabetes, no preeclampsia, anything like that. So it's been a fairly healthy pregnancy. And then her only medications that she takes are a prenatal vitamin, and then she also has Tums as needed for heartburn. So for her past medical history, this is all again still going to be in the subjective portion of the note. She just only has an allergy to cephalexin, which is an antibiotic. She had that one time for a UTI, like a urinary tract infection. Her family history is non-contributory. In cases of like labor and pregnancy, family history is like kind of a mixed bag of if it's like really useful or not. And then for social history, she works in software engineering, and her boyfriend is accompanying her today at the hospital. So now that we've taken a history and we've learned about like what her contractions are like and how she doesn't think that her water is broken, what would be our next step to rule in or rule out labor? Adam's saying check for cervical dilation. I love it. Yes, we're going to move into our physical exam, and that is exactly what we're going to do. So first, we're going to look at her vitals, and now you can put these in the objective portion of the note, and her vitals look all completely normal. So her blood pressure is 110/80. That's like a totally normal blood pressure. Heart rate is 88, still within the normal range. Respiratory rate is 18, again, Normal range, maybe a little bit high, but she's also got like a big baby like pushing up on her diaphragm. So that's pretty expected. She's saturating well with oxygen at 100%, and her temperature is 36.8 Celsius. So all these vitals look perfect. Her cardiac and respiratory exam are unremarkable, just regular rate and rhythm, has clear and equal breath sounds. And then for her abdominal exam, her abdomen is gravid. Like we said before, gravida is pregnancy. So gravid abdomen means that it's pregnant. It's also non-tender, and she has a fundal height of 39 centimeters. And we'll talk about that in just a second, like what that means. For her pelvic exam, her cervix is 6 centimeters dilated and 80% effaced, with the fetal head in a -2 station. And these are another couple of measurements that we're going to go through in the next couple of slides. So I don't want you guys to get too confused about this yet. And then we also see that her amniotic membrane is intact with no pooling of fluid in the vaginal vault. So that means that her water has not broken yet. So going back to the fundal height, this is a measurement that we take to give us approximate measurement of how big baby is. So a fundal height is the measurement from the top of the pubic bone to the top of the uterus, which is the fundus of the uterus. And so you're essentially vertically measuring the size of the baby bump. And the value of a fundal height is that the number of centimeters that you're measuring for a fundal height is approximately the number of weeks of gestation that you are, plus or minus 2. So with that being said, if our patient is 40 weeks pregnant, what would the range be for her expected fundal height? Any guesses? Yeah, perfect. So 38 to 42 centimeters is exactly right. So she was at 39, which puts her in the perfect range. Things that would cause you to be small for gestational age or like a smaller fundal height for what we would expect would be like growth restriction. And then for a large for gestational age, so like you're larger than we would expect for your gestation, would be things like possibly diabetes can cause babies to grow faster and to get bigger than we would expect them to. So that's like kind of why we take this measurement. And then, like we said before, for the pelvic exam, this was probably the most important part of our physical exam that we did. We saw that her cervix was at 6 centimeters dilated and 80% effaced and in a -2 station. This is usually how it's notated. I don't know what happened with this 6 and the centimeters. I know it should just be 6 centimeters, not centimeter 6. But this is how it's notated typically. And this is all telling us about the cervical ripening. So cervical ripening is the process of both dilating open and then the effacement, which is the thinning of the cervix in order to accommodate the passage of the baby. So if you look in this picture here, this is really highlighting like effacement. And if you look at how thick the cervix is when it's not effaced, it's usually like a couple of centimeters thick, and you wouldn't even be able to like pass a finger through the cervix. But then as you get more effaced, your cervix starts to thin out. It starts to kind of like shrink down in thickness, and that usually also accompanies dilation. So you can see it's starting to get a little bit more open here. And then when you're fully effaced and fully dilated, the cervix like essentially just disappears and it's completely open to allow for the fetal head to pass through. And then for station of the baby, it's measured as an estimate from the ischial spine of the pelvis. So that's like the neutral position where if the baby's head, let me see if the next slide has it or not. No, it doesn't, sorry. If the baby's head is like equal to the ischial spine of the pelvic bone, then that'd be a 0 station. Anything higher than that is going to be like a -1, a -2, and then a -3 is the highest. And then anything that's plus is going to mean that baby is like descending through the birth canal lower and lower into the vagina. So the closer we are to like a positive number, like a +3 is like baby is about to come out like right now. But then the ready to push phase is where the cervix is at 10 centimeters dilated and 100% effaced. So if you're not quite to 10 centimeters, then you're not ready to push. So for our differential diagnosis, the main thing here is like, we're pretty sure that she's in labor. She's 6 centimeters dilated. She's having regular contractions. They're getting more intense. They're lasting for longer, and they're getting closer together. However, we would still consider that before we did our exam, we would have considered maybe this is false labor, that she's not truly like progressing, but based on our exam and seeing that she is dilating, then we can rule out that this is false labor and that she's actively in labor. And then again, prior to doing our exam and prior to talking to her, one like do not miss diagnosis of having like these abdominal contractions would be like, you always want to make sure that they're not having that excessive bleeding or like a lot of pain in between contractions, because that can be a sign of a placental abruption, which is where the placenta starts to like separate from the uterine wall prematurely. And so that can cause a lot of bleeding into the uterus, and it cuts off baby's oxygen supply, and it's very, very dangerous for both mom and baby. So that's just one additional thing that if a patient comes in with like contractions, that you just want to ask them about like any vaginal bleeding or like anything out of the ordinary, to make sure that they are not having any scary complications like this. So then for the assessment and plan portion of the note, we have a 28-year-old G1 P0 female, meaning her first pregnancy, no children. And she's at 40 weeks and 2 days pregnant with no significant past medical history or pregnancy history. And she's presenting with signs of labor. Her contractions are 6 minutes apart, lasting for 1 minute. And her exam revealed cervical changes of 6 centimeters dilated, 80% effaced, and a -2 station with membranes that are still intact. So her water is still intact. She's not broken water yet. And based on this, we are going to say that the patient is in active labor. And so our plan is going to be to admit her to the labor and delivery department, so that we can continue like monitoring for her progress and assisting her with the delivery. So now that we have a plan, what kind of monitoring and tests do we want to have in place to make sure that mom and baby are safe during this process? Like, are we just going to throw her in a room and just be like, all right, good luck, let us know if you need anything? Probably not. So any ideas that you guys would have to like make sure that they're both doing okay? If you're like wanting some ideas, a good place to start is like with any patient that's admitted to the hospital, there's kind of like a standard set of things that we would want to be looking at. So like the patient's heart rate and vitals, blood pressure, things like that, that we would just be checking intermittently. And then similarly for the baby, that we can also like be measuring and tracking their heart rate as well to make sure that they are like responding appropriately to the contractions and such. And then Adam was suggesting that we would offer her an epidural. That's absolutely true. Yes. I actually did a virtual rounds on epidural a couple of months ago. So if you guys are interested in watching that, I think it's on the YouTube channel. That's definitely something that like the anesthesia team would come in and talk to her about, offer her different options for pain control, and then just kind of go with whatever patient preference is. So let's say that this patient is wanting to just do like a natural unmedicated birth. So she gets all the information that she needs. We'll hook her up to the monitors. And our plan is going to be hooking her up to a fetal heart rate strip, which is called I can never say this right, tocodynamometer. So this is going to measure both the contractions that mom is having as well as the fetal heart rate. And then we're also going to make sure that we're monitoring her vitals, including blood pressure, heart rate, and oxygen saturation. Usually we don't just like hook people up when they're in labor to all of the wires and monitoring and everything. unless it's like medically necessary, so that they can have room to like move around, or they can sometimes even like get into a bathtub and like have the warm water to relax and things like that. And then for checking her progress, typically cervical checks are done every 2 to 3 hours unless the patient is high risk, in which case we would do them more frequently. And then if patient wants to have like a less invasive or like more minimal checks, then we would do it less frequently, and just kind of like as needed. So a lot of labor and delivery is balancing like patient desires and what their birth plan is and what their intentions for their labor process are, with making sure that like you're still taking care of them and putting their best interests in mind, and like making sure that they're safe. I guess before we move on, does anybody have any questions about this case or need to go back to any of the prior slides? Does this like assessment and plan make sense to everybody? Cool. So if not, or if we need to ever go back, or if you have a question from like 10 slides ago, please feel free to still just like put a question in the chat, or at the end of the case, we can always go back and revisit whatever you need. Okay, so this is like a rough sketch of what a typical fetal heart rhythm or fetal heart rate strip would show. So we have this bottom line, which is showing the uterine contractions, and each sort of like wave going up is going to be like a contraction here. And you can see they're kind of like fairly regularly spaced apart with like lower activity in between. And that's when the uterus isn't contracting. And then the top line, we're going to see this sort of like fluctuating, but like pretty consistent line that is going to be the fetal heart rate. And so it's really important that we have these two things put together so that we can compare. So like at the same time that a contraction is happening, like how is the baby responding to the stress of the contraction? So there's a couple different ways that we can assess the fetal heart monitor. And one of the ways that we do is looking at what category it is. And there's 3 main categories that I want you guys to know, and I'll show like pictures with examples in the next couple of slides. But the first one is category 1 tracing. And this is like a pretty much completely normal, a completely normal fetal heart strip. So the normal baseline fetal heart rate is between 110 to 160 beats per minute. So that's obviously a lot higher than an adult, which is 60 to 100 beats per minute. And that's just like very typical and expected fetal physiology, is that they're going to have a faster heart rate. The other thing that we look at is the variability. So we actually want to see more fluctuations of the heart rate, or even like accelerations over 160 beats per minute in response to a contraction, because that shows that baby is able to like accommodate the stress of the contraction. We get more concerned if it's like minimal to no variability, because that means that they're like not reacting as well as we would like. So contrast that with a category 3 tracing. We're skipping 2 because 2 is kind of just like everything in between the 2. It's not very specific. But category 3 is like a very bad tracing, because there's either significant persistent fetal tachycardia, which is over 160 beats per minute, or even worse, fetal bradycardia, which is less than 110 beats per minute, with minimal to absent variability, and or if they have late decelerations. And I'll talk about decelerations in a couple of slides. So a category 3 tracing is definitely abnormal, and you need to intervene immediately, either to like implement a maneuver to try to correct the abnormality, or delivery if you cannot do that. And then, like I said before, anything in between is category 2. So you might have like a little bit higher, like more tachycardia, but there's still variability, or you can have some possible like decelerations, but they're like reactive. So it's kind of like if it's not one and it's not the other, then it just falls into this category. And this is not like as concerning as category 3, obviously, but it's still something that you want to keep a close eye on. So given that information, we know like normal fetal heart rate is between 110 to 160, but we would expect to see, you know, some accelerations beyond 160. What category would you guys put this image into, if you had to guess? And this blue strip here is showing like this is 110 and this is 160. So it's like approximately within that range. Perfect. Yes, Adam said category 1. Brianna said category 1. You guys are both correct. So this is showing really nice moderate variability. So like some peaks that are going over, but we're overall like pretty consistently within this blue line. And yeah, so this is a nice category 1. Their baseline heart rate, I guess you could call this like 145, 150. It's kind of hard to tell, but usually like you just need to know if it's like outside of the extremes, and if it's within, then you don't have to know the exact number. How about this one? It's not as pretty. I know it's like an old photocopy, but you can still tell. Any guesses for this? My go-to is I always look at what's the baseline heart rate first. Like if I had to draw just one straight line through where it is and try to estimate like where we're at. Yeah, you guys are right. This is a category 3. So we've got some significant fetal bradycardia. We're at like 100 beats per minute, which is below the 110. We've even got some of these decelerations here. You can see the dips that are kind of lining up with the contractions. Like this one here, we're almost down to like 90, 85 here. So this is definitely concerning for some pathology that's going on. We'd want to do an intervention. And then how about this one? So we've got like still like pretty minimal, but some variability. And I guess you could call this like maybe like 160 something. Oh, sorry, I just gave it away. My bad, you guys. This is category 2. So it's like still like a tachycardia kind of, but like it's not as scary as the category 3 that we just saw previously. And I would say like generally tachycardia is not as bad as bradycardia. Bradycardia is going to indicate that the baby's oxygenation and hemodynamic functioning is compromised. So this is a category 2, not super specific. Okay, so this is the other part of categorizing rhythm or fetal heart rate strips. So there's 4 different types of like accelerations or decelerations that we want you guys to be able to recognize. And a good mnemonic for this is veal chop. So if this nice little like veal chop that's on the side here. And we'll go through what each of these looks like, but just to kind of review all 4 of them. So the first type that we're going to talk about is a variable deceleration. And the appearance is kind of sketched off here to the side, but like you can see these are where the contractions are happening. And the decelerations is like where it drops below the baseline, but it's not happening exactly correlated with the contraction, because like we're dropping here and then we go back up to normal and then we drop again like before this contraction has even started or like reaching its peak. And then we kind of accelerate like right as the contraction is going up again. So this is variable where it doesn't really follow a specific pattern. It just kind of has this like jagged appearance. The next one is early decelerations. And this is going to look like a mirrored image of the contraction. So you'll see like the heart rate kind of dropping down at the same time as the contraction. And then once the contraction starts to let up, then the heart rate is going to return to normal. An acceleration is not even pictured here. This is part of the 4th image here. But an acceleration is like what we saw in that first category 1 tracing, where you just kind of have these spikes that are going up. And that's actually normal. And we want that to happen because, again, that's just telling us that the baby is responding appropriately and physiologically to the contraction stimulus. So accelerations are okay. And then the last one is late decelerations. And you can kind of see in contrast to the early decelerations where it's the mirror image, this is going to be like pretty clearly off to the side, like after the contraction has started to pass. That's when the heart rate's going to drop. And this is definitely the worst out of all of the different types of morphology that we're seeing, because this one is indicating placental insufficiency. And we'll go through like these causes and the treatments again once I show you guys the like what they look like. So just to remind you, veal chop, and this is going to correlate with the cause of this abnormality here. So if V goes with C, variable is going to go with cord compression. So if an umbilical cord is like compressed either against the side of the uterus, or if it like starts to prolapse down through the cervix, or if the fetal head is like pressing against it or something, then that's going to produce this pattern. And I like to think of it as kind of like a sawtooth down. So they're not always as like, this is obviously like a not an actual patient's thing, and it's just like an illustration. So this is a little bit more like exaggerated. But if you like have your baseline still, where you try to draw like approximately where your baseline is at, and then you're just having decelerations down at random intervals, like we talked about, then that's going to be a variable deceleration. And the treatment for cord compression is going to be repositioning the mother and trying to take the pressure off of that cord. So that's variable. And then C, cord compression. So that's the first V, and C in veal chop. The second letters, E and H, early decelerations, which is that mirrored image that we talked about. That's going to go with fetal head compression. And contrary to what it seems like, you don't actually really need to treat these. And I'm going to be honest, like, I don't really know why it produces this and like why we care about it if you don't really need to even treat it. But it's just like not going to affect the outcome of the birth. Like the baby's health is not in jeopardy. I don't know the like mechanism for why, if the head's being compressed, it affects their heart rate, but that's just like how it is. So this is another one of those non-concerning patterns that we see and that we don't have to do anything about. The third one, accelerations, is okay. So that's that third letter in the veal chop. Okay meaning normal. And I kind of, again, think of it as like these little sawtooths that are going up. So if we estimate that the baseline is like somewhere around like, let's say 130, but then we have these spikes that are going up to like 150 or so, then that's just like a normal response. And you can see they kind of correlate like loosely with the contractions and like when those are happening. And so we don't have to do anything again for this one. And then the last one that I was talking about, the late decelerations, this is the most serious. And here you can kind of see, like, if you line up where the contractions are going, like the deceleration occurs like after the contraction starts to let up. And the reason why we are so concerned about this is because it is caused by placental insufficiency. So examples of placental insufficiency would be like a really severe preeclampsia, possibly like placental abruption that we were talking about before, where you have like separation of it from the uterine wall. If you have like maternal hypotension and the mom's blood pressure is really low and she's just not perfusing really well, then that can also be a cause. Basically, all of these things are just like bad things that we need to treat right away. And if we can't treat the cause of it like right now, if we can't fix it right now, then we need to treat it with delivery. And sometimes that means C-section, like emergency C-section. So last in veal chop, late decelerations is placenta. I'm just going to go back to show you guys the veal chop again. So whenever I have a rhythm or I keep saying rhythm strip, that's not a rhythm strip. Whenever I have a heart rate strip in front of me, I just like write down veal chop in this way, and it helps remind me like what I'm looking for. And so if you like for the quiz, if you guys need to write that down, then I recommend doing that. It's just a nice, easy mnemonic that reminds you all the things you need to know. Okay, so going back to our case, our patient labors for several more hours and she progresses to 10 centimeters dilated, 100% effaced, and is at a +3 station. Yay. So now we're looking at her baby's fetal heart rate strip and her contractions. What does this strip show us? And what, if anything, do we need to do? What category would we call it? Are we seeing any decelerations? Like what would you guys say about this strip? Also, look at how nice and strong these contractions are. She's definitely getting close. Okay, so this is actually, I think, maybe the same category 1 picture that I used a little bit earlier in the slides. But so we see like this nice, like approximately like 150 baseline heart rate with some accelerations in response to the contractions. And so this is like a totally reassuring strip that we are seeing right here. And we can just continue to let her labor and push and do what she needs to do. So given that she's 10 centimeters dilated, it is time for her to push. She pushes for an hour, and after an hour, she delivers a healthy baby girl. She does, however, sustain a 2nd-degree laceration to her perineum. Does anybody know what a perineal laceration is? Any guesses? Yes, unfortunately, is the dreaded vaginal tear. So, I picked like the most mild looking pictures that I could, you guys. In real life, it is obviously not this clean. But there's 4 different degrees of tears that you can have. And it's perineal laceration. So the perineum is like the skin or the tissue that's between, like in males, it's between the scrotum and the anus. And in women, it's between the posterior edge of the vagina and the anus. So a 1st-degree laceration is just going to go through that first top skin layer only. It's just the vaginal mucosa. This is the most mild form of tear. And sometimes you don't even need to suture it. You can just like, if it's really mild, it can even just look like a little scrape or an abrasion and you can just leave it alone. A 2nd-degree tear is going to go through some of the perineal muscles, but it's not going to extend all the way down to the anal sphincter. So our patient, since she had a 2nd-degree tear, you kind of go layer by layer. You stitch up the muscles and then you stitch up the overlying skin. If they didn't have an epidural or if their epidural is not working, then we, of course, are going to numb up the area with like a local anesthetic like lidocaine, give a couple shots of that so that they don't feel the needle and that they will have a little bit longer lasting pain relief after we do the repair. This is where it gets really scary, especially as a woman. A 3rd-degree tear is where you go through the anal sphincter, the external anal sphincter, because you actually have 2 anal sphincters, fun fact. Your external one is the one you actually have voluntary control over, and your internal one is one that you don't have control over, and that's like what makes you feel like you have to go. So tearing through the external anal sphincter in addition to these other perineal muscles. And so it's kind of the same thing, like you're going to numb them up, you're going to suture them up. You just have to keep like doing more sutures. It's going to require more sutures and you have to just, again, go kind of like layer by layer. And then the most severe tear or laceration is a 4th degree. And this is where you go all the way through the rectum. This is like my greatest fear. Because obviously like that has to be incredibly painful and like not just when it happens, but then like everything that happens afterwards, like you're already postpartum and now you have to worry about this too. But again, the repair is going to be pretty much the same. You just like suture each muscle layer and go all the way up to the skin. Very scary. So for this patient, she was 2nd degree. So we repair the laceration by numbing the area with lidocaine. Like I said before, it's a local anesthetic, and then suture the wound closed. Mom and baby are now recovering and bonding together, and she thanks you for the excellent care you provided during this important life event. So yay, happy ending. And I would say also mostly, at least from my limited experience on labor and delivery, that I've never seen a 4th degree. I've maybe seen a couple of 3rd degrees, but most of them I'd say are 1st and 2nd. So like fingers crossed that if you or someone you know like gives birth, that they don't get to that stage. Okay, so I always like to do a little bit about the specialty that we talk about today. And in the past, I've talked about OBGYN specifically, but for labor and delivery, I wanted to talk about all the different ways that you can get to being able to deliver babies. So the number one way that people always think of is becoming an OBGYN. This is going to be a medical specialty that requires either an MD or a DO, plus a 4-year-long residency. So the differences between OBGYN and some of the other things is that you can perform surgeries, like you can do C-sections, you can do other gynecologic cares that maybe other people wouldn't be able to do necessarily. And OBGYNs, because they're so highly specialty trained in pregnancy, they are the ones who are responsible for the more complicated and higher risk pregnancies and deliveries. A couple other ways, though, that you're able to be a person who delivers babies. Family medicine, people sometimes don't know this, but if you're a family medicine physician, you are trained in and can deliver babies as well as provide prenatal care. So for family medicine, it's again going to be a either MD or DO plus a 3-year-long residency. So it's one less year because it's not a surgical residency, but you are also being trained in like almost every other part of healthcare. Family medicine doctors do like everything, and I have the utmost respect for them. So they can provide basic prenatal care, and they can attend and perform uncomplicated vaginal deliveries. And they can also provide pediatric care for the baby once the baby's born, as well as postpartum care for the mother. So that's one difference between like the OBGYN and like the certified nurse midwife, is that the family medicine can care for the baby and the mom after the baby's born. And then for a certified nurse midwife, if you are like somebody who's maybe just like interested in healthcare, but not sure if you want to go to medical school, and you're considering nursing, then you can still be like an attending provider in labor and delivery as a nurse trained professional. So if you get a bachelor's of science in nursing, plus either a 2-year master's or a 3 to 4-year doctorate in midwifery, then you can also be the like main provider who can attend and perform vaginal deliveries. You can also provide basic gynecologic primary care and prescribe things like birth control and those sorts of things. You can't do C-sections, and you would only be caring for like women's health type issues. So that's kind of like the differences between these different pathways. I've worked with all of these different providers before, and they're all excellent. I think like before going to medical school, I didn't know what a nurse midwife was, or I thought that they were like not as qualified, or that they were like, I don't know, kind of like not as Western or like evidence-based, but they're actually at my institution, they're faculty in the College of Medicine and not even in the College of Nursing, but they like teach medical students and work with residents as well, and are excellent providers that use evidence-based medicine, and they just have a little bit of a different approach to it, which some women really prefer. So all of these people are excellent options for prenatal care and labor and delivery. These are my sources here. I wanted to plug this obefm.com. If you're interested in any like OBGYN or labor and delivery topics, this is just like an entire library of these fetal heart rate strips and different like quizzes and ways that you can practice reading them. So if you're interested, I would highly recommend checking this out, and everything I think is free. So yeah, if you're interested, just head on over there, I guess.